I will talk about an important issue. These are my disclosures. An important issue is about atrial fibrillation. You know that atrial fibrillation is not coming alone. Patient with atrial fibrillation comes with multiple comorbidities like hypertension, diabetes, heart failure. So the thing which is important here is we have to treat the atrial fibrillation not only in reduction of the risk of stroke, we have to take the patient as a whole package and treat him, because this will decrease the comorbidities and mortalities. So we have to quantify these risk factors in order to get a good optimal result with the patient. All of you know that atrial fibrillation is more prevalent in diabetic patients. More than 40% about patients with diabetes will have, or atrial fibrillation have diabetes. Unfortunately, it's more in women than in men, those who have atrial fibrillation, and whether women found to have diabetes. You know also that diabetes and the atrial fibrillation is a dynamic process. There is a dynamic process regarding the pathophysiology, between atrial fibrillation and diabetes. You can see here that the glycemic fluctuations, inflammation of diabetes, all of these will increase the oxidative stress. This will lead to many structural remodeling, electrical remodeling, and also autonomic imbalance. All of these will lead to the appearance of atrial fibrillation in those who have diabetes. On the other hand, chronic kidney disease is an important issue also. هو سيف ذو حدين. Chronic kidney disease, عجز الكلى, سيف ذو حدين. شلون سيف ذو حدين? Patients who have chronic kidney disease will have more stroke incidence. Not only that, the patient also will have more bleeding incidence. So the patient who has atrial fibrillation, already he has a risk of stroke. And the patient who has atrial fibrillation with chronic kidney disease, the stroke incidence will increase. Not only that, atrial fibrillation with chronic kidney disease will have bleeding incidence more. You know that atrial fibrillation are taking anticoagulant drugs, and those who have chronic kidney disease, they will have the risk of bleeding from these drugs. So there is two important parts of chronic kidney disease we have to know about. Now we come to a daily practice. Patients who have diabetes, he is old age, he has diabetes, he has chronic kidney disease, and he has also atrial fibrillation, non-valvular atrial fibrillation. How we can address such a patient in the treatment. You can know that a patient with chronic kidney disease also there is interaction with diabetes. Patients who have diabetes will have more three times more chronic kidney disease. And this will increase the mortality and morbidity in those patients. All of you know this Charles-Vasse score. It is important, I will not go through it. But our patient is more than 75 and he has diabetes. So he has Charles-Vasse 2. And according to the guidelines, he is a candidate of taking anticoagulation. Those who are females should be 3 and more. You know that the female is also a risk factor for stroke. Other thing that you know that once you have more risk factors for atrial fibrillation, stroke, the patient atrial fibrillation risk factors, the patient will have more stroke and more incidence of stroke. Not only that, we have to also address an imbalance with the bleeding tendency in those patients. So the Hasbled score is important, and you have to address it and balance the risk of stroke and the risk of bleeding in those patients. So atrial fibrillation in association with diabetes and chronic kidney disease will impose a high risk of comorbidities and stroke. You know that atrial fibrillation تقريبا 5 مرات عندهم risk of stroke. Diabetes 2 times, and تقريبا 16% of those patients with chronic disease will have also stroke incidence. مثل ما تعرفون انه المرضى اللي عندهم multiple risk factors, the cardiovascular mortality and morbidity will increase. As you can see here in those patients, diabetes alone, chronic kidney disease alone, and diabetes with chronic kidney disease, they will have increase in the cardiovascular and total mortality. So it is important to take the patient as a whole package and treat him to decrease and reduce these incidents of bad nasty events. age-related risk factors. شافوا انه طبعا الروكت AF is you know all the it's a trial comparing rivaroxaban with warfarin. It has showed that those patients who are more than 75 years of age, they will have, it is not inferior to warfarin to use rivaroxaban in reducing the stroke events. Also, it is also superior, and there is a little bit less incidence of critical and life-threatening bleeding risk. There is a prospective study was published in the SC in 2019. It's called SAFR AS prospective study. هذول شافوا المرضى اللي عندهم atrial fibrillation وأعمارهم أكثر من 80 سنة دخلوهم in the inclusion criteria in regarding rivaroxaban. شافوا إنه إذا نقارنها ويا الوارفرين شافوا إنه major bleeding, intracerebral hemorrhage, stroke and mortality was significantly less in those patients who are taking warfarin. So it is safe to use it in old age, frail patient. احنا دائما نخاف المريض اللي عمره 80 سنة وفوق نخاف له يصير bleeding, نخاف من ICH, نخاف من fatal bleeding. So when we give the rivaroxaban in the optimal dose, the patient will have less bleeding, less intracerebral bleeding and less major bleeding, but the stroke and the mortality was not significant, but it was non-inferior. What were actual fears of the patient who have presented to you? You know that the rocket, you know that the rocket AF patients with rocket AF, they have stroke events less and cardiovascular death less. Also, we have to know that management of the risk factors of cardiovascular disease complements the stroke prevention in a way that it will decrease the burden of atrial fibrillation and the symptom severity. So when we treat the heart failure in a patient with AF, when you treat diabetes in an optimal way, the patient will get more benefit and you will get less mortality and morbidity. Can we protect him from being amputated? Patients who are diabetic, the risk of amputation, risk of diabetic foot, okay? So if the patient has atrial fibrillation and he's diabetic, does this, and he's taking rivaroxaban, does this decrease the rate of amputation? Yes, it has shown that in comparison with warfarin, there was significant reduction in the amputation rate. So it is not only reducing the stroke, it will reduce also the amputation rate in those patients. What about chronic kidney disease? As I said in the beginning, chronic kidney disease is a risk of stroke because there will be more pathophysiological effects in the procoagulant effect. Also, it will increase the severity of bleeding because you know that the mechanism of action, it will decrease the clear out or the wash out of the drugs that are used as anticoagulation, and also it will increase mortality. So we have to address chronic kidney disease, which is very, very common in patients who have atrial fibrillation. You can see here that the primary efficacy, the patient is used, for example, rivaroxaban. We can use it in moderate renal dysfunction. Rivaroxaban, you know that the creatinine clearance, if it is more than 50, you have to use it in a 20 milligram dose. If it is less than 50, up to 30. Below 30, we have to be cautious. But between 50 and 30, it is used in 15 milligram. It has shown that it will decrease the risk of stroke and also decrease the risk of bleeding, critical bleeding, ICH, and fatal bleeding. So it can be used safely in those patients, don't worry. Kidney preservation. شافوا انه المرضى اللي عندهم chronic kidney disease 50 وجوه creatinine clearance وياخذون ريفروكسابان راح يستفادون انه يحافظون على مستوى الكدني فانكشن، ما راح يصير deterioration. بالمقارنة إذا شفنا warfarin with excessive anticoagulation there will be more bleeding. شافوا إنه راح يقل kidney function with doubling of creatinine. You can see that the decrease in the GFR, doubling of creatinine, acute kidney injury and kidney failure is better when we use it with rivaroxaban instead of warfarin. So it has a beneficial effect on the maintenance of the kidney function.
Only 2 minutes.
I think you have two more slides. Yes, okay, I will finish. إذا نقارن الإيفيدنس مثل ما تشوفون apixaban, dabigatran, rivaroxaban in the kidney failure شافوا إنه there is more preference and favoring the use of NOACs instead of warfarin in those patients. Now, what are the 2019 focused update in the ACC guidelines? It has shown that over time, NOACs, dabigatran, and rivaroxaban may be associated with lower risk of adverse renal outcome than warfarin. So there is an there is an intention to use those NOACs and those who have chronic kidney disease to preserve the function of the creatinine, or kidney, sorry. Appropriate dose benefits, مثل ما تعرفون, it is used once daily, so it has a privilege over other NOACs and those who are taking twice daily. المريض دائما من ياخذه يقول لك انا اخذ حبايه دكتور بسبب السعر، بسبب انه يتعاجز ياخذه، بسبب the poor adherence. فلهذا المريض اللي ياخذه مره واحده هو المفروض ياخذه مرتين. This might affect the risk of stroke and does not affect the risk of bleeding. So when you use it once daily, and it is better adhered by the patient than when you use it twice daily. You can see here in comparison between rivaroxaban, dabigatran, and apixaban. So it is an issue. شافوا انه المريض اللي ياخذ once daily is more adherent to the NOACs than the patient who is taking NOACs with 2 daily doses. تقريبا ثلث المرضى اللي ياخذون 2 daily doses will skip 1 dose, and this will affect the rate of stroke. مثل ما تعرفون هو الدوز هو 20 ملغ، هو هذا اليوجوال دوز. اللي عنده كرياتين كليرنس اقل من 50 الى حد ال 30 نستخدم 15 ملغ. So don't be afraid. As doctors, we are afraid from hemorrhage. As doctors, we are afraid of hemorrhage. The patient is afraid from stroke. So we have to balance these fears, 2 fears, okay? As I said, also, although we can use it in elderly patients, it is safe. So don't be afraid by using those patients, but we have to select the proper dose, which is this important. So in conclusion, the patient is having comorbidities and he has atrial fibrillation in non-valvular AF, I mean in non-valvular AF. What is the patient if he has diabetes and NOACs? We can use NOACs, especially rivaroxaban I'm talking about. It will prevent a stroke, preserve the renal function, reduce liver amputation, mitigate the bleeding risk. It will reduce the bleeding risk, also prevent cardiovascular death, protect following stent placement, and optimizing the dose because it's used only once, also supporting the adherence of the patient, which is all important. So we treated the patient as a whole package, and we maintained his health in a good way beyond only stroke prevention. And thank you for your listening.